It turns out that the common assumption that mental health is simply the absence of mental illness is completely backwards. Mental health and mental illness exist on two intersecting but distinct continua, meaning a person can have a diagnosed mental disorder yet still experience optimal mental health, or, conversely, have poor mental health without a diagnosable disorder.
Really? That's kind of surprising. I mean, most people just think if you don't have a mental illness, you're mentally healthy. But this suggests it's way more complex than that.
Exactly. And that complexity has real-world stakes. How we assess, treat, and support people in psychiatric mental health nursing depends on understanding this nuanced relationship. It pushes us to look beyond just diagnostic labels and consider resilience, social context, and functioning.
So by the end of this episode, listeners will get a clearer picture of how mental health and mental illness interact, how culture and social factors shape diagnosis and care, and how psychiatric nursing is evolving in Canada's changing landscape.
Right. Let's start with the dual continuum model from the EPP report back in 1988. It proposes two separate but intersecting scales. One for mental disorder, ranging from maximal disorder to absence of disorder, and another for mental health, from optimal to minimal.
So if I'm understanding this, someone could be at the extreme end of mental disorder but still have optimal mental health? That sounds contradictory.
It does at first, but think about a person with chronic schizophrenia who is stable on medication, maintains social connections, maybe works or volunteers, and follows a healthy lifestyle. They still have a mental disorder, but they function well and cope effectively. That's optimal mental health despite the disorder.
That's a powerful example. And then the ideal state would be absence of mental disorder plus optimal mental health. Basically, what we all hope for.
Exactly. Then there's the quadrant, where someone has no diagnosable disorder but minimal mental health. Poor coping skills, low resilience, maybe struggling with stress but not meeting criteria for a disorder.
And finally, maximal mental disorder with minimal mental health, like severe illness combined with poor coping, such as in borderline personality disorder.
Yes, the key takeaway is that mental health is dynamic. People can move along these continua over time, and nursing care needs to address not just symptom reduction, but also promoting resilience, coping skills, and social integration.
That really shifts the focus from just treating illness to supporting overall well-being. But I imagine culture plays a big role in how mental health and illness are defined and understood.
Absolutely. Mental health and illness are culturally defined and socially constructed. Take the historical diagnosis of hysteria, for example. It was linked to restrictive gender norms and sexual repression, mostly diagnosed in women, and faded as social attitudes changed.
Right. And then there are culture-bound syndromes, disorders recognized only within specific cultural contexts, like running amok in Southeast Asia where a person suddenly engages in violent behavior, or Pibloktok in Arctic regions, involving uncontrollable urges to expose oneself to extreme cold.
Exactly. These syndromes highlight how culture shapes what behaviors are seen as pathological. But some disorders, like schizophrenia and bipolar disorder, are universal, though symptom expression and interpretation can vary.
So for psychiatric nursing, this means assessments and interventions must be culturally sensitive to avoid mislabeling nonconformity or culturally normative behaviors as illness.
Yes, cultural competence and humility are essential. Nurses need to understand the patient's cultural background deeply to provide effective care.
That makes sense. Now, shifting gears a bit, the diathesis stress model is the prevailing explanation for mental illness, right?
Correct. It integrates nature and nurture by proposing that mental illness results from the interaction between biological or genetic vulnerability, diathesis, and environmental stressors or trauma.
So neither genetics nor environment alone is enough to cause illness, but together they can trigger it.
Exactly. For instance, major depressive disorder might develop in someone with inherited brain chemistry alterations, or in someone with little genetic vulnerability but significant environmental stress causing neurochemical changes.
That also explains why identical twins can be discordant for schizophrenia. One develops it, the other doesn't, depending on environmental factors.
Right. For nursing, this means holistic assessment is crucial. considering genetic predispositions, life stressors, and social determinants of health.
Speaking of social determinants, resilience seems to be a key concept in mental health recovery. But it's not just an individual trait, is it?
No, resilience is best understood as a dynamic process and outcome shaped by complex cultural, social, and physical ecologies. Michael Unger's research emphasizes that resilience depends on navigating and negotiating resources in one's environment, not just personal grit.
So it's about how people interact with their social and physical surroundings to manage adversity, rather than just bouncing back on their own.
Exactly. Resilience involves optimism, mastery, competence, and emotional regulation. Early experiences in emotional regulation enhance neurobiological coping mechanisms, particularly in the prefrontal cortex.
That's fascinating. And nursing practice should focus on strengthening resilience, not only at the individual level, but also within communities and systems.
Yes, and the nurse-patient vignette from the document illustrates this well. A nurse named Brenda acknowledged a patient's shame and stigma about bipolar disorder, which helped the patient build resilience and move toward recovery.
That kind of empathetic, culturally sensitive care can make a huge difference. Now, what about the epidemiology of mental disorders in Canada? What are the key points?
Well, roughly 1 in 7 Canadians, about 5 million people, use health services for mental illness annually. Women aged 25 to 39 are more likely to use these services, while boys under 15 are more likely than girls, reflecting the prevalence of conduct disorders and ADHD.
And dementia contributes to high prevalence among older adults, right?
Yes. Almost 1 in 4 people aged 80 and over use services for mental illness, largely due to dementias. Comorbidity is common too. Many individuals have multiple concurrent disorders.
Are there notable provincial differences?
Definitely. Manitoba has the highest prevalence of any mental disorder, including major depressive disorder and alcohol use disorder. Nova Scotia leads in substance use disorders, while Quebec and Prince Edward Island have the lowest overall prevalence.
And suicide rates vary significantly, with Inuit populations in northern Canada experiencing rates far above the national average.
Exactly. These epidemiological data are vital for guiding resource allocation, prevention strategies, and clinical focus.
Moving on to classification systems, the DSM-5 is the primary manual in North America, correct?
Yes, published in 2013. It lists over 350 mental disorders and organizes them developmentally and by symptom clusters. It emphasizes person-first language, diagnosing disorders, not labeling people.
And globally, the ICD-11, published in 2020, is the standard, translated into over 40 languages.
Right. Canada currently uses an enhanced version of ICD-10 called ICD-10CA while preparing for ICD-11 implementation. Both systems incorporate epidemiological data and social determinants to varying degrees.
Nurses rely on these classifications for diagnosis, care planning, and communication.
Exactly. Now, psychiatric mental health nursing in Canada is unique because there are 2 regulatory bodies, registered psychiatric nurses in the Western provinces and Yukon, and registered nurses with psychiatric specialty under the Canadian Federation of Mental Health Nurses.
That's interesting. And nursing diagnoses use standardized systems like NANDA-I. With over 240 diagnoses, many related to psychosocial and psychiatric care.
Yes, and the Nursing Outcomes Classification and Nursing Interventions Classification provide frameworks for measuring outcomes and defining interventions.
Basic-level nursing interventions include coordination of care, health teaching, milieu therapy, and pharmacological monitoring.
While advanced practice nurses can prescribe psychotropic medications, provide psychotherapy, consult with other professionals, and take on leadership roles.
So psychiatric nurses play a critical role in promoting mental health, supporting recovery, and addressing stigma.
Absolutely. Looking ahead, there are several challenges and evolving roles for psychiatric mental health nurses.
Like the aging population, which increases the prevalence of dementias and the need for community-based, ethical, person-centered care.
Yes, and cultural diversity, decolonization, and anti-racism are priorities, especially given the mental health consequences of colonization and systemic racism in Canada.
Nurses are in a key position to bring culturally safe and anti-racist practices into patient care and organizations.
Then there's expanding technology. The Human Genome Project has advanced genetic research, offering promise for identifying at-risk individuals and targeted medications.
But it also raises ethical questions about privacy, consent, and potential discrimination.
Exactly. Nurses will be central as informed educators and caregivers navigating these issues.
Telepsychiatry and virtual care have expanded access, especially in rural and remote areas, but require adaptation of nursing roles and competencies.
And finally, social determinants of health. Income, education, social support, racism, and more profoundly impact mental health. Nursing practice must integrate upstream interventions and advocacy.
Nurses are positioned to lead in policy, education, and practice innovation to meet these challenges.
So practically speaking, mental health and illness are complex and demand nuanced assessment beyond diagnostic labels.
Cultural competence and humility are essential to avoid misdiagnosis and provide effective care.
Resilience building should be a core nursing intervention, recognizing systemic and ecological factors.
Epidemiological awareness informs targeted interventions and resource allocation.
Nurses must also navigate evolving technologies and ethical dilemmas while maintaining patient-centered care.
And collaboration across disciplines and sectors is critical to advancing mental health outcomes.
To sum up, psychiatric mental health nursing is not just about managing symptoms, but about empowering individuals within their social and cultural contexts to achieve the best possible quality of life, regardless of diagnosis.
That's a powerful reminder of the humanity at the heart of this work.
Absolutely. And stories like Elizabeth Anderson's recovery journey highlight this beautifully. She lives with schizophrenia, but leads her own recovery, supporting others through writing and community work.
Her recipe for recovery includes 6 ingredients: timely intervention, the right medications, supportive people, a reason to be well, a reason to hope, and something important to do, a higher purpose or calling.
That encapsulates the essence of recovery and resilience in mental health nursing.
Well, this has been a deep dive into the complexities of mental health and illness and the evolving role of psychiatric nursing.
Indeed. Hopefully listeners come away with a richer understanding of these intersecting continua and the importance of culture, resilience, and holistic care.
And the critical role nurses play in shaping mental health care now and in the future.
Exactly. Thanks for engaging with us on this important topic.
Thanks. Until next time.